All right, so to get this started, introduce myself really quickly. I'm Joe Morrison, co-founder and CEO of Right2Breathe. Was caregiver for my dad for a little over 10 years while he had COPD before he had passed away, and my mother-in-law still lives with COPD today. This is obviously a topic that is very personal and something I'm very passionate about, and I'm really excited that we have partnered for this meeting as well as the second Tuesday in November to discuss things about the Spiration valve system. So really, it's I'll let Dr. Hogarth talk a little bit more about it, but you can see in the picture it's just this small little umbrella-shaped one-way valve that gets placed inside the airways of a diseased lung. So obviously, I'm going to let Dr. Hogarth talk about it because I am not a clinician, and he certainly has many years of experience working with lung valves. So with that, I'm thrilled to welcome Dr. Kyle Hogarth. He is an expert in pulmonary diseases. He is from the University of Chicago Medicine and going to basically give us an overview on the Spiration valve system. And the goal really is to teach everybody what the valve system is, what the procedure's like, who qualifies, and then how you could find more information to find a treating physician in your area, that sort of thing, if you're interested. What we're going to do is we're going to hold all questions until we get a little further along, and we're going to go through some frequently asked questions, and then there will be plenty of time for you to ask your own questions. So with that, I would like to turn the meeting over to Dr. Hogarth.
Well, thanks so much for having me. I'm actually spent the morning doing bronchoscopies. This is our bronchoscopy suite where we do this procedure. Actually, we just did a patient this morning. So I'm happy to talk about this. I've had an experience actually thinking about it. I've been using this device now for 15 years, was involved in one of the original clinical trials, and then was involved in its use for a non-emphysema application, and then was in the pivotal trial that finally brought it to approval in the United States. And once approved, we've been obviously busy trying to help patients. So this is an Olympus disclaimer, as you can see here. I'll let you read that. But the contents in this presentation is for information and background only. And obviously go to this website if you want to learn more about the full information about the Spiration valve. So we're going to go through the disease state in general, and then more importantly, talk about the valve treatment and what they're trying to do and the type of patients that have the potential to benefit from these, and then work on obviously being able to find a resource for yourself, for friends, for anybody watching, etc. There is a skill set involved with knowing how to place these. It may be something that you may have the best doctor in the world who takes care of you, but they may not know how to do this procedure. And so people who do this procedure work very closely with a number of physicians to be able to take care of this component of your care, and then obviously have you return to the care of the doctor that you've developed a relationship with. So let's go through the disease. When we talk about COPD, it is definitely an umbrella terminology. It is a grab bag diagnosis, and it represents both emphysema, chronic bronchitis, even actually fixed obstructed asthma, and even some forms of bronchiectasis, which is an airways damage disease. It's not about splitting hairs. Ultimately, the symptoms are very similar across for majority of patients, with coughing and wheezing and shortness of breath and not being able to catch your breath and tightness in the chest, etc. And so, labels are just that, though the valves do target, and one of the requirements we'll come back to, is a proportion of emphysema within the lungs. If someone truly has non-reversible asthma, for example, it may be very symptomatic, but that person wouldn't benefit from valves. And we'll go through some of the details on that. So with emphysema, and again, it's part of COPD. The best way to think about it is the lungs are a spongy-like material that have a lot of elastin. You stretch them out and they snap back to their shape. And that elasticity is lost. And so they stretch out and they stay stretched out. And they get more stretched out and they stay stretched out. And you get enlargement of the air sacs as well. And as a result, you get this hyperinflation. And that hyperinflation is where a lot of the breathing challenges come in. For people who don't have COPD or emphysema, one of the easy ways to sort of understand what it might feel like is for someone to take a very deep breath, hold it there, and without breathing out, now go walk around just keeping your lungs fully inflated. And it's extremely challenging. And it obviously is not even remotely the same as having the disease, but it is a way for people without the disorder to have some understanding of what it feels like to be a patient with COPD and emphysema. Needless to say, this can have a huge impact on people's quality of life, the activities that they're able to do, limitations, etc. And of course, there can be a lot of breathlessness and a lot of fatigue. The work of breathing to power those lungs is more than a healthy set of lungs. So it's not surprising that a lot of COPD patients are very fatigued by the end of the day, as quite literally the work involved with breathing is much higher for them than the average person, even of the same age. So treatment-wise has traditionally been pretty straightforward. The obvious, avoiding triggers and smoke, secondhand smoke, etc. Even more important in today's world with vaping, and even more importantly, because smoking tends to mean cigarettes, but obviously with multiple places with legalized marijuana, as far as the lungs are concerned, smoke is smoke. It's flu season now, obviously, time to get your flu shot, be up to date on your pneumonia vaccine. There's rescue inhalers, and then more importantly, in the last decade have been really nice advances in the inhaled medications. There are multiple brands on the market, but the long-acting drugs have made a big difference in the management of COPD. Many of you, I'm assuming, are on them. In some cases, people ultimately need oxygen or combinations of these drugs. One of the things that's underdone and underutilized right down here is pulmonary rehab. COPD robs you of your endurance, it robs you of your strength. Pulmonary rehab helps to restore that second, regardless of whatever lung benefit someone has when we measure their lung capacity. Someone in the severe category is where obviously oxygen treatment comes on, and things like the surgical lung volume reduction, though that's a very limited surgery, and of course lung transplant as well. But long before we're talking about that, we should be talking about bronchial valve therapy, bronchoscopic lung volume reduction using the Spiration system. The surgical procedures, for example, with lung volume reduction, was a very complicated procedure with a lot of significant pain and suffering and a prolonged hospital stay and complications, etc. The valve treatment, our average procedure is about 20 minutes, and there's no cutting involved. So you can already see the marked difference. So let's talk about it. So this is essentially what they do look like. It was stated earlier, there's sort of an upside-down umbrella. And schematically, and the concept is quite simple. If this airway is the area that heads off to the extremely damaged lung, think of it like a branch on a tree that's dead, and this is the airway that heads off to the healthier portion of the lung, then why would we want to send any air to the sick part? We'd want to be shunting everything we could to the healthy part. But more importantly than that, this part that is taking up all the space, remember we talked about all that hyperinflation. A lot of people's emphysema is not distributed equally. And so this branch in this picture is leading to a portion of the lung that's taking up so much space, it is squishing the healthy portion so that it can't open and close and do its work. So if we don't let any air in, but we let all the air out, then the sick portion will ultimately collapse. And that's the idea. It's one-way valves placed in the airways to the most diseased portion to direct the air to the healthy portions and keep it from going to the sick portions, causing those portions to collapse down in size to allow the healthier portion to expand. So some descriptions. We got these small anchors that help hold this thing in place so they're not going to come out. This is the removal rod that allows us to take it out if necessary. And then the umbrella design to help obviously let air not get in. Right up front, these anchors help hold this thing in place and they will stay in place. But what is also nice, and one of the things I like about this procedure for my patients is, as you know, like all things in this world, responses are always a bell-shaped curve. There are people who are perfect candidates for this and get an amazing response. Then there's the average response, which is excellent. And then there's a group of people who really get nothing from it, and despite being a good candidate. And there's some theories as to why that may be, but I think equally important, if these aren't helping you in the slightest, we don't want to leave them in you. So we can simply go back in, grab them, and remove them. It's pretty rare in medicine that you get to hit the undo button when it comes to a procedure. And valves actually represent the ability to do the undo button. We hope never to have to, but it is nice to know that if, with the best of intentions and the best of studies, you, the individual, do not get a response or even feel worse, well, then we want to at least get them out of you. So who is a candidate? So you do have to have emphysema, and you have to be still symptomatic despite having the medications and rehab, or if you're on oxygen, etc. In other words, you have to be doing the best we have, short of the valves, but still limited, still having trouble getting around. The valves work in select patients whose the air in one part of the lung, that part is more diseased than another. So if the emphysema is equal throughout all of the lungs, that we don't have a target, the valves are not going to provide a benefit. So what we do to figure this out is just two tests. One is full pulmonary function tests, which I'm sure everybody has had. It's not just the simple spirometry. It is a measurement of your lung volumes. We need to know how big your lungs are. And equally important, if not more important, is the CAT scan, a CT scan without an infusion, simply to quantify the emphysema, to look to see if you have an area with more disease and another area with less disease, and that what's called the fissure, the barrier between the lobes of your lung, is intact or not. Conceptually, if we are going to be trying to shut the front door to a region of your lung, and we're going to let all the air out, you can't have a back door refilling you as I empty you. So what ends up happening is we see people in our clinic, and they are sick. They fit the criteria up here, but then when we do the CAT scan, we discover that unfortunately they are not candidates, not because we don't want to help them, but what we learned through all the years of the studies is who these valves won't help at all. And if they have no chance of helping you, why would I put you through a procedure? So you are not a candidate for valves if the following things are going on. If you're not able to tolerate a bronchoscopy, but I will tell you in expert hands, that is pretty much nobody. If you're sensitive or have an allergy to nickel, thankfully not common, but the valves are made of nitinol, which contains nickel. If you are still smoking, this is, we need to talk. If you have massive bulla, so emphysema is a bunch of tiny holes, but some people have huge, massive, one big, almost balloon inside their chest. The valves won't help there, but also there's a really excellent surgery to fix that person. We talked about certain types, if the emphysema is just everywhere, obviously if you're actively infected at the time, and if you have already had treatment in that portion of the chest where they have had to remove part of your lung or done what's called a pleurodesis, where they essentially have, for lack of a better word, glued the lung to the wall. If we're wanting to collapse a portion of your lung and that region of your chest has been invaded before by a surgeon, then the valves will not work. But thankfully, this is a small proportion of patients who are not candidates. So we review your CAT scan. We obviously then, once you are a candidate, we do the sedation. We do ours under anesthesia. The procedure is quick, of course. And then we measure the size of your airways, going to that targeted lobe, place the valves through the bronchoscope. So we go right through your mouth. There's no cutting. And then obviously place the valves, and away we go. So there's the bronchoscope being placed. No surgery needed, of course. There's the valves inside the catheter. So folded up like the umbrella. Then deployed, and once deployed, no air going to the sick portion. And then that sick portion starts to collapse down, and you get more expansion of the healthier portion. People can take deeper breaths. They're able to then do more. We typically require people to stay overnight. And the reason we do that is at a minimum 1 day, but typically for 2. The reason we do that is that as we are collapsing the one portion of your lung on purpose, we are expanding the other portion of your lung. The other portion of your lung has some emphysema. There is a chance that as that part expands, that one of those emphysema bubbles will rupture, will pop. And then the other portion of your lung will also collapse, which is not what we want. Because the risk for that is highest in the first few days after the procedure, we monitor you so that we can obviously fix that if it was to occur. What I tell people is it gets called a complication, but in reality, this pneumothorax, that's what it's called, it's the popping of the lung. It's not technically a complication, it's a consequence. If I collapse down the portion of your lung, if the valves do exactly what I want, then as that other part expands, the chance of it popping does happen, and it is a byproduct of the success of the valves. Thankfully, it's still a relatively low risk, though it's, we wish it was zero, and it's obviously something to talk about with your doctor. Now, obviously, we'll see it with x-rays to see how you do. We'll monitor you for complications, and then obviously carry it home and then follow up and continuing to exercise. And obviously, if you had these valves and you started having chest pains and more trouble breathing, that would be a sign of a pneumothorax, of your lung popping, and you'd want to seek immediate attention. Thankfully, this complication, this problem, is something that any emergency room is prepared to handle. So, for example, if we did your procedure, you went home and you're an hour away from my hospital, and this happens to you, a week later, you're not going to drive the whole way to my medical center. You're going to go to your nearest emergency room, for example. Now, the benefits. What are you going to get for all this? So, when they looked at scores of breathlessness, these are validated scales, we had an almost 30% decrease in the rate of shortness of breath, high quality of life. To put it into perspective, a lot of the inhalers you take reduce the quality of life score. Lower is better. Reduce the quality of life score by 4 or 5. Here we had a 9.5. This is staggering, especially because the type of patient we put valves in, the more advanced disease, get less benefit from the inhalers to begin with. So to see results that are more than double than what we would normally expect from the inhalers is pretty impressive. A major reduction in that hyperinflation. So remember I said this is sort of the way the chest is. You deflate, so now you have the ability to take more deep breaths as I act that out. These are the risks, of course. Pneumothorax, that's the big one we talked about. You can have some acute worsening of your COPD at the beginning. There is always a little bit of risk of bleeding from the metal in the valves. The risk of death, I will expand on this because I presented on this. One patient in the studies died. I will say specifically they did not die directly from the valves because here's what happened. Their lung did collapse. They had the pop. The local emergency room, when they put the tube in, which is a standard procedure and there's a specific way to do it, and whatever way this emergency room did it was not remotely the correct way, and they pushed the thing all the way into the patient's artery, and the patient essentially bled to death instantly. Some frequently asked questions. Will I be able to feel the valves in my lung? The short answer is no, not at all. Will I feel better after the procedure? The amount of time is variable. There is a portion of patients that I said who don't respond at all. So you might be perfect. They might be placed perfect. Everything ought to be perfect. And on follow-up imaging, you have no collapse. You don't feel any better. There's some theories as to why that is, but the problem is we can't prove it. And so we have no way to predict it ahead of time. So if you are an ideal candidate, there is a chance that these valves will not help you. But thankfully, a majority of people do get the benefits we talked about. How long will they stay implanted? They're implanted to stay permanently. They are meant to stay in there permanently. And will they stop or decrease my oxygen or other COPD medications? The short answer is no. You will not get off oxygen. Your medications will not change. In fact, if anything, your medications will stay exactly the same, but they will work better. But definitely you will not get off oxygen. How many valves will be placed? The average is 4, but it really does depend on your anatomy. The inside of our lungs are like fingerprints. Everybody's are different. So we've had one patient only need 2, and I've had a patient need 9. The average is 4, but it really doesn't matter. Just the more valves slightly increases the length of the procedure, obviously, but not anything astronomical. Length of recovery, it just, again, depends. The anesthesia time is short. There's no pain afterwards except for a sore throat. Sometimes people get some chest discomfort from the collapsing that we want of the targeted lobe, but we have them walking around the hospital pretty much right afterwards. Then when they get home, we want them to restart rehab. So the recovery is pretty quick because there's no surgical time. You're not being cut on. So in fact, when they work the way we want them to do, you're able to breathe deeper right away, and so you're able to be more mobile. Can they be coughed out? The short answer is no, only because when we size them correctly and they have those little anchors. The only way this could be coughed out is if quite literally a mistake was made and the wrong sized valve was placed. If your airway is a 7 millimeter airway and someone puts a 5 millimeter valve in, those anchors aren't going to be embedding into the tissue. They'd be loose. But to be honest with you, it's not really sure to me how that could happen. So technically, yes, they could be coughed out, but realistically, no. And in none of the trials, it never happened. Does the doctor ever need to go back in? Sort of. They do need to obviously see you with x-rays and breathing tests and so forth. Once in a while, we've had to go back in. One, if there's a question of a change in your mucus. Two, if there's ever been a question about pneumonia in the targeted area. Or three, if you tell me you keep bringing up some blood, not intermittently, but regularly, we'll go back in and make sure that they're not scraping it in an airway and might have to adjust it. But as far as a regular, we're just going to go in and look, no. How to find a doc? The Spiration Valve System webpage. Basically, go to the Patients and Family section, the Find a Physician button, and you get, for example, if you're in the greater Philadelphia area, you'll see some of the various docs. This is an example. Obviously, it's all over the U.S. And the list of everybody who performs these procedures. I actually know both of these people quite well. They're good friends of mine. So if you happen to be in this area, seeing either one of them will do you just fine. So you can obviously search by state or address, city, and zip, or use the Google Map features, etc. It's unbelievably easy to find that doc near you who does the procedure. The Spiration Valve Facebook page is there as well, a patient website there as well. But the whole idea, of course, is to give your lungs the ability to work more efficiently. And so with that, I'll be quiet and say thank you, and thanks to Olympus for having me, and Right2Breathe, and happy to entertain any questions. I will stop my screen sharing.
Excellent. I am going to unmute all. I'm going to ask that those of us who, if we try to take turns, it's obviously if I'm unmuting everybody, then there's the possibility of everyone talking over each other. So we'll try to take turns.
If everybody could, though, if you're not actively speaking at the time, keep yourself on mute just to minimize the background.
Exactly. Yeah, but you'll be able to control the mute yourselves at this point. Right. So yeah, if you're not actively speaking, please keep your put yourself on mute. A lot of you are muted. So okay, with that, I'll stop speaking and see if anybody has any questions.
I have one. A quick question, Doctor. The portion of the lung that's blocked off that basically is meant to collapse to allow the good lung or the good portion of the lung to expand. Eventually, does that bad portion of the lung simply disintegrate and become absorbed into the body?
No, it just stays collapsed down. What happens is that the normal blood supply that keeps the lung alive, which is separate than the portion of the blood that that changes oxygen, that will always be maintained. The portion that obviously goes to supply oxygen, that spigot, if you will, gets turned off, and so that portion of the lung just essentially sits there, for lack of a better word, because the valves do move. That's how they let air out, but that's also how secretions get out.
So, in other words, that's the reason that the valve is designed to be permanent, because if that portion of the lung simply disappeared and became reabsorbed, I don't know what the medical term would be, then at that point you would remove it because you wouldn't want this foreign object floating around within the thoracic cavity.
Correct, but if you take them out, the lung will re-expand.
It will. Okay.
Yep.
Thank you.
You bet.
Cool. Good question, John. Go ahead, Karen.
Okay. I had a friend many years ago who had these Zephyr valves
Yep.
implanted in
Yep.
her. Unfortunately, she did not have a good experience.
Okay.
And what is the difference, the basic difference between Spiration and Zephyr valves, and of course the surgical LVRS, which years ago a pulmonologist recommended for me, and I said I'm not there yet.
Sure. So at the core, so there are technical differences between the Spiration valve and the Zephyr valve that are more technical in the sense of the engineering of the device. And obviously, both companies' marketing departments will have things to say about their valves. But at the
Of course.
but conceptually, they're identical in that you are trying to occlude a sick region of the lung to let the air out. So both the Zephyr valve and the Spiration valve, what they're trying to accomplish and how they accomplish it is identical. So those two devices are both available in the U.S. And like I said, there's technical and medical pro cons, if you will, to the doctor who places them. But from a and you know, again, marketing departments will tell you why one's better than another.
Yeah.
But from a patient's perspective and from just an engineering perspective, what they're trying to do is the same. Now, surgical lung volume reduction is a procedure that is well validated, but obviously fraught with complications and also not done very often. And so one of the problems you have is that surgical procedures that are complicated and with a significant amount of complications behind them, you need surgeons who do a lot of them. And so this is a surgical procedure that is very limited on who's allowed to do it, where Medicare will cover it, and is limited on the exact type of patient who can get it. It's also, of course, permanent because they are going to quite literally prune the dead portion of the tree here, if you will. But it is the surgical procedure that has shown in the right patients improved long-term mortality as well as quality of life. Neither valve has shown a mortality benefit. They've only shown quality of life. So we don't know if valves make you live longer. We do know they make you live better. We know the surgery, there's an upfront risk of death, but that people who get the surgery live longer. But there are very limited centers who do the surgery. You're welcome. Now, I will say there are right now, because obviously there are people who don't qualify for valves, like we talked about, where their CAT scan, you know, they are sick. We would love to place them in them, but that we know they won't work. You know, they have holes in the fissure, etc. Thankfully, and you can obviously find all these things on clinicaltrials.gov, there are multiple studies that are about to launch for new devices to try to help for people who are not valve candidates. And so now these are research, so there's obviously not an FDA approval, etc.
Right.
But for people that are interested in that, there are still some potential options. I always remind everybody, every device at one point started as research. You know,
it did.
I placed a patient. I did valves on a patient 12 years ago as part of a research trial. You know, she was one of the first. So
brave lady.
Yes,
to be one of the first. Well, thank you.
You're welcome.
I appreciate that.
If your lungs are very large as a result of severe emphysema, does that sort of mean you're not a good candidate because it's not localized enough? The problem.
Well, no, we do want your lungs to be large because it is the hyperinflation that we're trying to fix. But the key is that because of the distribution of emphysema, if both my hands are someone's lung, but a portion of it is really enlarged and full of emphysema, what ends up happening is because the chest is only so big, so this healthy portion gets squished, and so it's like a bear hug on the healthy portion. So if I shrink down the sick portion, the healthy portion can expand and do more work.
I see.
That's the concept. Think of it like literally when you have a tree with a dead branch. When you cut that dead branch off, the rest of the tree fills in the space and looks all pretty again. And without the specialized, without the CAT scan, there's no way to know if you're a candidate for these valves You need the breathing test to see how hyperinflated you are, to have how much what's called gas trapping. When you go to breathe out, that you can't, but then that you can't empty your lungs fully. The CAT scan then tells me, do you have a target area? Do you have a portion of your lung that I need to go place these valves in?
So you're looking for a large residual volume to show
Correct.
the air trapping. But
Correct.
are you also looking for more localized emphysema opposed to homogeneous?
Yes,
Or
very much so.
so that's part of it, as well as looking for, as you mentioned, the fissures, and there's another term for that I can't
Correct.
think of. But
No, it's the fissure integrity. That's exactly it.
But the homogeneous emphysema wouldn't be able to be cured by this, right?
Correct. This procedure wouldn't help that person.
And I think one of the reasons I brought that up, Mary, I hope you were done, because I'm certainly not trying to speak over your questions. But I pop into a Facebook group from time to time that is specifically for lung valves, people that have questions, and someone will say, well, my doctor says that I'm not a candidate, I don't qualify. And people will jump in, and again, these are all just patients trying to help each other. Will say,
Sure.
well, go get a second opinion. Oh, you go find another doctor. And I'm thinking to myself, if you don't qualify, you don't qualify. And running around is going to be the most ridiculous thing. But are there some patients where one doctor will say you're not a candidate, but another doctor will say you are? How cut and dry is it?
No, so it all depends on why they were told they're not a candidate. So, for example, if your doctor without a CAT scan and without any breathing test says you're not a candidate, you should go get a second opinion. If you come to see someone who does valves, so someone like myself or anybody else on those lists, and we do your CAT scan and we do your breathing test, that's the two tests I need, and then we say you are not a candidate, it is precisely because from the criteria for the valves to work, you're not a candidate. You can go get 100 more scans and go see 100 more doctors, and every one of them is going to say exactly the same thing, because it's not me not saying you're not a candidate. It is your CAT scan that says you're not a candidate. And it is when we say even emphysema, that's a grab bag term, because one person's emphysema is not the same as the next person's. You might line up a group of people who are all very short of breath, who are all on oxygen, who are all on the same inhalers, and they all go to the same pulmonary rehab class. And some of those people are going to get valves, and some of those people are not going to get valves.
Yeah. Okay. Thank you.
Yeah.
When the lungs collapse, and there's that hole there, how does it heal up? Or does it take a long time in a diseased lung to heal?
You mean like if the lung popped? If the lung popped?
Yeah.
So we put a chest tube in, so it's a thin piece of tubing between the ribs to suck the leaking air out to help that lung re-expand. In some scenarios, if we can't get the leak to stop, because you're right, the lungs are diseased, it can take a little bit longer. So in some cases, all you have to do is give it a few days and it will heal. The lung will heal that hole. But for some people, unfortunately, the hole will not heal. The air will keep leaking out. And so in that situation, what we have to do, because in order for the lung to heal the hole, the lung has to be able to touch the chest wall. So we have to go back in and take one of our valves out so that the full lung will re-expand so that we can get that hole to fix. It depends on the individual, but there's a protocol we follow for, if the lung pops.
And it usually works out when you do
Yes.
the inflation.
Yes.
Is it 30% of the lungs collapse, or?
So it depends on which study you're referring to and which valves. So the Spiration valve study, the rate of pneumothorax was lower. The various studies with the Zephyr valves have shown ranges of pneumothorax. Our own clinical practice, what I quote to all of my patients, because I don't want to sugarcoat it, and I want people to understand what they're signing up for, is I quote everyone a pneumothorax rate of roughly 25%. That is probably higher than the reality of the world, but I also don't want anybody, I don't ever want to be the doctor that's downplaying the risks. I tell everybody there's about a 1 in 3 chance you're not going to respond. And I tell everybody that, not at all, it won't work. And that there's also a 25% chance we're going to pop your lung when we do this. And it's not me trying to scare you, but it's definitely me not trying to talk you into it. And it is a very safe procedure, and we know how to handle these complications. But I also don't want someone thinking that, hey, just show up, I'll drop these valves, you're going to go run a marathon, right? It is about making sure that, I'm a big believer of a very informed patient before I go doing any poking and prodding.
I think most people, that's what they want in a physician anyway. So,
Right.
I mean, certainly if I was the one coming to you for, for this potential procedure, that's exactly what I would want personally.
Yeah,
But,
I'm not in the business of talking someone into the procedure. I'm going to lay out the facts. I lay out the benefits. I will say, from my opinion, what I think I do like about this is the ability to remove them. So that if we put them in with the best of intentions and you do great in the sense of the procedure goes smooth, but you come back to see me in clinic and you're like, I am not better at all. In fact, I am worse. You didn't get any collapse, and obviously we've closed off portion of your lung, and you needed that portion of the lung, and you say, Doc, this hasn't helped me at all. Then we're going to take them out. I actually have a guy that we're taking him out this Thursday because we did him a couple of weeks ago, and he is not better at all. In fact, he is arguably worse. And so, we'll undo, and he'll go back to how he was, which of course is not what any of us want either. But, it's better than where he is today.
But why is he worse?
Well, because he didn't collapse at all. And so he didn't collapse in the slightest. And so remember, this area is diseased, but it still does some breathing. And now I've closed it all off. So I've basically removed a portion of his lung, but without giving him any benefit of expanding the other portion of his lungs.
Oh.
So that's why he's worse. So that's why we're going to take him out. Then that part of the lung will do the breathing again. And he'll go back to how he felt, before I met him.
And I would assume the Olympus company that manufactures the Spiration valve, they track and follow all this, so they can hopefully learn from it also.
So we all have been. There's registries that are starting, and there's also the physicians who do these procedures. Advanced bronchoscopists and interventional pulmonologists were a subtype of pulmonary physicians, and we ourselves are very interested in trying to figure out why some people don't respond. Now, look, there are some simple reasons people don't respond. If I didn't size the valves right, or they didn't get placed right, and they're not sealing your airway, if this is your airway, and I put a valve only this big in, there's air going through. I gotta fit it in. So, outside of technical issues, but there's a group of people who everything's perfect. The valve is exactly where it needs to be. There is nothing, quote, wrong here. You're the right patient. The valves are the right size, location, etc. But you don't get any collapse. Now, the reason that may be is that even with a perfectly intact fissure, there's some possibility that there's still some small holes that we're not able to see on CAT scan, so that you don't collapse because you still fill up. There's also the possibility that people with COPD and emphysema, if they've ever had an exacerbation, sometimes and most people have, those flares lead to inflammation along the lining of the lung, and that leads to the sticking of the lining of the lung to the chest wall. So, and you can't see that on CAT scan. So they can't collapse, or they're not able to.
Right.
And so they try to, but they're not able to. And there's no way to prove that, unfortunately.
And you work in the trial with Jerry Kreiner, or you work with him now, or you just know him because you now do the procedure?
All the above. I've known Jerry for a while. Like I said, those of us that do this, the field of bronchoscopy is relatively small and still relatively new.
Yeah.
And so those of us who are doing a lot of the work and a lot of the research, we kind of all know each other because we all, in normal times, go to the same meetings.
Yeah, right. Yeah, Jerry's a great guy.
Yes, he is.
If you do well, how much better would you be? Like in the best case?
Well, as you saw, the average data show the massive improvements in quality of life, improvements in the lung function and sense of breathlessness. What someone's able to do with that is individualized, because of course, you see this in a pulmonary rehab class. Again, you can line up all the people of the same age and the same lung function. What people are able to do with that lung function is not, it's not your FEV1 number that's part of pulmonary function testing does not always dictate what you're able to do. But that sense of breathlessness starts to get relieved the less hyperinflated the lung is. And remember, there's limited number of doctors who do these procedures. Just because your doctor doesn't do the procedure, that's fine. Go see someone who's done it. And because there's enough technical challenge, you should very much ask the physician how many they've done. Not that it's wrong to be their third patient ever, but you're going to have a better chance of success if you're their 100th, for example.
Go ahead, Andy.
Yeah, just really nice to listen to that, Kyle.
Thank you.
It's bedtime in the UK now, so I'm going to say good night, folks.
Good night.
Yeah,
Good
and
to see you, Andy.
that was really
Thank you.
interesting, Kyle. Thank you very much.
My pleasure. Thank you.
Kyle,
Well, you have only one bronchoscopy to do the lung volume reduction. Frequently, people only have one target. The data that I presented is doing one bronchoscopy, one set of valves. There's been a few patients that we've had where they've had two targets, and so we've come back months later and done the other side. That's not the standard.
But you don't do like 4 or something, 2 in each lung, or
No, not at all.
always all in one lung.
Correct. Typically people only have one target anyway. But even if they have two targets, I always have to assume I'm going to pop your lung. And if I pop both your lungs, you're going to die.
I get it. Okay.
And I'm not in that business.
Not a good alternative.
That's not my business.
Yeah.
I'm in the opposite business.
Something about the Hippocratic Oath or something like that.
Yeah, and I remember somewhere someone told me to do no harm. I wasn't paying attention.
Absolutely.
But the number of valves that you will put into one lung will depend on the severity, the target areas. Every situation is different. It could be
It's
2, it
just
could
the
be
anatomy.
4.
It's just the anatomy. If your left upper lobe is the target, you typically get one in the apical segment, one in the posterior, 2 in the anterior, and 2 in the lingula. That's sort of the generic average. But some people's, apical segment's huge, and they don't need 2. And the posterior segment's huge. They don't need 2. I've never seen the same set of lungs twice. Everybody's lungs on the inside are markedly different. The valves are sized both very much by the diameter, and then not just the diameter, but also you have to have a place to put the anchor. So some people's anatomy, where one valve might have fit across the circle, I actually have to go deeper and put 2 valves because the airway is so short and stubby, it needs to get blocked off on the 2 deeper ones. No way of knowing that till you get in there. So you make a lot of so-called game time decisions while you're in there, but that's the whole sizing process. That's
Right.
part of the procedure.
The main thing I'd like to know, and I probably missed it throughout the thing, is does like Medicare and Medicaid pay for the lung valves, and are they pretty reliable once you have them?
So Medicare does pay for them. Medicaid would depend on each individual state. I know Illinois covers it. The commercial insurances have generally covered them. There's always some rare exceptions. That's the nature of insurance. But Medicare does cover them. And the valves are reliable both in their ability to stay and their consistency in outcomes. That's where the data was presented and ultimately where the FDA approved them. They are part of guidelines on how to manage COPD as well. That's one of the reasons why they have such excellent coverage. All right.
True.
Thanks, everybody. Thanks so much for having me.
Thanks so much, Dr. Hogarth.
Thank you very
No,
much.
my pleasure. Thanks, everybody.
Thank you, Dr. Hogarth.
All right.
Thanks so much,
Take
everybody.
care.
Good evening. Bye-bye.
Bye-bye.